A very good evening to all of you. WINCARS is back again. We all know that WINCARS takes great pride in having education and academics as one of its basic priorities. And when it comes to academics, of course, students are what we seek for, and we look forward that they can gain more and more knowledge through more and more seminars, as well as keep themselves abreast with the clinical knowledge. And today we have none other than one of the masteros in clinical medicine, our worthy advisor and senior faculty member, Professor Dr. Jyotsna Maddury, who has always taken keen interest. Despite her health or anything, she's here for all the students to teach them and guide them so that they can get the best of everything. And I'm very happy that Dr. Richa Sharma, our very active WINCARS member, has kindly consented to be one of the examiners and share the case which they recently did in their institute. And I think she's here to unfold along with her student, Dr. Parag Gupta. I'm joined by our E class coordinators, Dr. Cecily Majella and Dr. Sowmya Kasturi. So, all off to you. May I request Dr. Jyotsna ma'am and Dr. Richa ma'am to go ahead, and our examinee, Dr. Parag Gupta, is here to present his case.
Yeah, thank you, Shibba. Starting this initiation once again in the new year. And I request Richa to introduce the student and go ahead with the case.
Very good evening, everybody, and thank you, Shiva ma'am, for such a kind introduction, and thank you for giving this opportunity here to present this case of us, which was quite complex and intriguing initially, and eventually we unfolded with the diagnosis, and now management again remains a complex part in this particular case. So I would like my DM student, he's a third year student, Dr. Parag Gupta, to present this case. Parag, you go ahead with the case presentation.
Yes. Good evening, everyone. Today I'm going to present a clinical case presentation. I'm presenting a case of 21 years old male, which was a farmer by occupation, resident of Sultanpur, Haridwar, belonging to a lower middle class according to modified Kuppuswamy classification. Patient is informed by himself and history seems to be real. Next slide. Patient presented with the chief complaints of palpitations since 6 months and shortness of breath on exertion since 4 months. Next slide. History of present illness. Patient was apparently asymptomatic 6 months back, following which he developed palpitations, which were gradual in onset, continuous, fast and regular in character, lasting for a short duration, relieved on its own and on taking some rest. There was no association with any syncope, lightheadedness, no diurnal variation, or there was no history of passive excessive urination after the spell. Next slide. Patient also complained of dyspnea on exertion, insidious in onset and gradually progressive, starting from NYHA 1 to currently to corresponding to NYHA 2, aggravated during farming in the field in the farmhouse, and it was relieved on taking rest. It has not progressed to NYHA 3 or 4. There was no history of any orthopnea, PND, which is present nocturnal dyspnea, pedal edema. There was no history of any chest pain, syncope, pre-syncope, or giddiness. There was no history of any fever in the childhood, any recurrent sore throat infection. There was no history of any cough, recent surgery, or prolonged immobilization. There was no history of any weight loss, heat intolerance, tremors, and there was no history of any generalized weakness or AC fatigability. There was no any past history of diabetes mellitus, hypertension, asthma, or TB. There was also no history of any migratory joint pain or any recurrent infection in the past. Family history: the child was born of non-consensual marriage, and there was no history of any sudden cardiac death in the family or similar cardiac illness in the family. Personal history: appetite was normal, bowel and bladder was normal. It was having mixed diet, normal sleep pattern. He was non-smoker, non-alcoholic, and there was no significant weight loss. Also, the drug history: there was no significant drug history. Differential diagnosis were: first is
Parag,
the valvular heart disease.
Parag,
Yes,
please
ma'am.
summarize your history. Then your differential diagnosis comes.
Okay, ma'am. My patient is a 21-year-old male who is a farmer by occupation belonging to a lower middle class, presented with the complaints of palpitation, gradual in onset and relieves on its own from the last 6 months, and also associated with the shortness. There was also complaint of shortness of breath from the last 4 months, currently NYHA 2. There was no history of any orthopnea, PND, chest pain, syncope, or dizziness.
So, with the history of the palpitations, what you got it, what do you think the cause for the palpitation?
Ma'am, palpitations, it can be according to the age. If we jump to the cardiac, before the cardiac, it can be due to, as according to the age, it can be anemia, or and it can be due to thyroid, hypothyroidism, thyrotoxicosis, and others. It can be due to valvular heart disease, and
Uh,
it can be due to some drugs intake.
Parag, it is better to say the palpitations when you got the history, whether it is
Yes, ma'am.
related to the volume overload or
Okay,
related
ma'am.
to the arrhythmic episodes. Because you are thinking
Ma'am.
it is a cardiac, it is not a non-cardiac cause, like anemia
Okay, ma'am.
and all those things.
Okay,
Still, you
okay,
want to
ma'am.
consider that, then you say is the non-cardiac, then
Okay,
volume
ma'am.
overload, and then you tell that. That is a better conclusion whenever you take the history. Our aim is from the history is to come to a conclusion, what is the reasons for it. So in
Okay,
the
ma'am.
chat box, someone said that is volume overload. So
Yes, ma'am.
in that it is what is a classical picture of the description of the volume overload versus arrhythmic palpitations?
Arrhythmic palpitations are, ma'am, sudden in onset and sudden in offset. But here, in my case, the patient has a gradual onset and it's relieved shortly on. Also, it was regular. It was not irregular. So it was not arrhythmogenic.
uh, Regularity doesn't make a difference whether it is a volume overload or to that of the arrhythmic episodes. Arrhythmic episodes also can be the many of them are the very regular. If in SVT, do you get an irregularity? You don't get it. In the AF only, you will get the irregularity. So
Yes,
that
ma'am.
doesn't distinguish it. So the major thing is the first thing is the description of the type of the palpitation, as you said, that onset and offset. And the second one is exertion related or not. And what is the
Yes, ma'am.
posture? Is it a posture related or not? All those things will they tell. So the major description of this is looking like a volume overload, but not that of a arrhythmia. That's what you meant it.
Arrhythmia. Yes, ma'am.
Good. And what about the dyspnea? What is the dyspnea says? Dyspnea is progressed from the class 1 to class 2 for how long? And class 1 since how long?
Last one was initially, ma'am, first 15 days, then it progressed to class 2 in the last 3 months.
Means it is a
But it
very
has not
short.
progressed to class 3 after class 2. It was just on exertion, doing the farming and doing these activities.
But relatively short history for the dyspnea. To you to consider to the DDs what you gave it, many of them are the long-standing ones. That's the reason why I asked you have to be very, very careful of the class one to classify. Many of the times we don't consider the class one as a dyspnea at all. The patient doesn't really complain. You have to go and ask for how long they have it. But okay, all said and done, you said only 15 days for the class one and deteriorated to class two, which is a faster
Yes,
one.
ma'am.
But it is not a further deteriorated in the 3 months. But a whole
Yes,
history
ma'am.
of the dyspnea as such is less. So now you tell your causes of palpitation associated with a deteriorating dyspnea from the class 1 to class 2. So now you can talk about your differential diagnosis.
Ma'am, it can be a
And
valvular heart
you
disease.
wanted to say in this order, and why you wanted to put this first as a valvular heart disease, a congenital versus rheumatic, all those things you tell, you justify in saying it. Richa, please, you can also interact it just
Yes,
because
ma'am.
you're a student, that's why I'm asking. That's nothing more than that.
Yes, ma'am. Yes, ma'am. Sure. Yes, Parag.
Congenital because of the age factor, I'm saying more.
Rheumatic can also present at this age, and it is a usual presentation of rheumatic heart disease in
Yes, ma'am.
this 21-year-old male. So, what are the features that are supporting your diagnosis to be congenital rather than rheumatic? You have given a negative history, so just elaborate those negative histories.
Ma'am, there was no orthopnea in PND, no,
No,
no chest pain.
other than that,
Hmm.
there was no such
There was
inciting
no
event
recurrent
of
throat
ah,
infection
yeah,
or recurrent LRTI in the childhood, ma'am.
or no migratory polyarthralgia or
Polyarthritis,
polyarthritis.
ma'am.
Yes, yes. So there was no such history. There was no
How
such.
frequently you get rheumatic fever history in a rheumatic heart disease? Do you know the natural histories of the rheumatic fever?
Yes, ma'am.
Please
15
quote
20%.
the natural histories.
Hmm. Approximately, I'm 15 to 20% cases.
Mm. Natural history is approximately nahi rehta hai. It won't be there.
Yes.
Anyway, it's obvious that you have to read about the rheumatic and fever history, and many frequently you don't have it. Only the half of the people will have this in rheumatic and fever history. You don't have the half of them, and the two, in a case of the what valve involvement, makes a difference. Okay, please go ahead. And Waller heart
Ma'am,
is very broad. Whenever you are going for the you are exam going student, no?
yes, ma'am.
Yes.
Better not to say as a Waller heart disease. Waller heart disease and classify something else you have to say it. Which valve, whether it's stenotic or the regurgitant, it has to start like that. Saying a Waller heart
Regurgitant more than stenotic here, ma'am, due to volume overload.
and so broad thing to say that after the history is not reliable. You have to think about the palpitations with the dyspnea, and but the dyspnea is a shorter duration, and
Yes,
palpitation is
ma'am.
almost at the similar time. So you start with the stenotic lesions and say that what stenotic lesions are more likely, like the whether you wanted to consider then mitral stenosis, because palpitation is also is an important history, and so you have to
Ma'am,
consider the stenosis versus.
we have to, if we consider mitral stenosis, then we have to consider the AF. The AF is most associated with the that there was no history of any sudden offset onset palpitations. So I was taking more regurgitant lesion more than the stenotic.
So more than these leading questions, you should able to tell in that format. Whenever
Okay,
you
ma'am.
are saying that the differential diagnosis in the Waller heart disease, I want to consider it because Waller is going to be this the first diagnosis, the many of the conditions, and you have to be more specific what you are talking about it. Okay, please go ahead.
Okay, Parag. Ma'am,
Ma'am,
you
there can be
wanted to
valvular heart.
explain other? Yeah, yeah. Go ahead.
There can be valvular heart disease. Uh, more regurgitant lesions more than the stenotic. In the regurgitant, there can be aortic or mitral. Aortic is more here. There can be congenital heart disease such as atrial septal
Why
defect.
would you why would you say aortic more than mitral? Your second differential is mitral valve prolapse. So
Yes,
you
ma'am.
are implying that it has to be mitral regurgitation.
Ma'am, because the history of dyspnea was very small. There were no significant NYHA 3 or 4 and no orthopnea and UPND. It was more of palpitations involvement.
So that can happen in mitral regurgitation as well.
Yes,
So
ma'am.
the question would be, how would you differentiate between, how would you just say that aortic more than mitral or mitral more than aortic? Because you yourself have given the second differential of mitral valve prolapse.
Yes, ma'am.
So
So palpitation
what
Mm.
can be because of AR or MR, both.
Yes, ma'am.
otherwise
Mm.
indirect question is what makes the difference for the MR to be present more than that of the AR? In the MR, what happens? Directly the regurgitation occurs into the left atrium and directly
Yes, ma'am.
transmitted to the pulmonary veins. So the pulmonary capillary wedge pressure rise is
Will
much
increase.
rapid in the case of the MR, whereas
MR.
AR has a protective effect of the left ventricle. Unless it is the pressure is raised or the failure then occurs, then it transmits it's the pressure to the left atrium, and then you will have the pulmonary edema features because of the capillary wedge. Even though the acute MR, acute AR presents with the pulmonary edema, there is a left ventricular protective effect, which is not their case in the case of the MR. Okay. Why you consider mitral valve prolapse?
Mitral prolapse, ma'am, because the patient is having history of dyspnea with palpitations, ma'am.
But is that natural history of the mitral valve prolapse is like this? 15 days of class 1 and 3 months of the class 2, and palpitations
No,
are the
ma'am.
only months. Okay, even though you considered, but natural history doesn't fit into the mitral valve prolapse. Okay, why you want to consider adaptive atrial septal defect?
Ma'am, atrial septal defect is there. Mm. because the patient is
When actually palpitations occur in ASD? I expect the other students are also to answer
ma'am,
the in the chat box.
because of increase the force of contraction, ma'am. There can be a
No,
shunt lesion,
it is a shunt lesion. It
palpitations,
is an overload, volume overload
volume
situation.
overload.
So, when does palpitation happen in AST, Parag?
Ma'am, volume overload condition due to force of contraction will increase.
When you have arrhythmias, atrial fibrillation because of the dilatation, your RA, they dilate, RA dilates, then arrhythmias happen, AF happens in AST, then
AST.
palpitations will happen. And that is an arrhythmic palpitation.
Yes, ma'am.
One of the reasons for palpitation in AST. The other is volume overload, of course. But as and when it is a hyperkinetic kind of ASD, the shunt, because of the shunt happening, it will not lead to palpitation because of volume overload. It is arrhythmia which leads to palpitation in ASD.
That is true. Usually, you don't get the volume overload signs producing the palpitation in them unless it is arrhythmic in episode. So, your description is not suggestive of an arrhythmic in episode, so is the less likely to the happen it. So, yeah, what I modification I wanted in the differential diagnosis is valvular heart disease is not good enough. You have to tell specifically what you considered in the different valves, what you considered, and then go ahead. Please go ahead for the clinical presentation. Anything else, Madam Richa? Can we go over?
I'm happy with the differential diagnosis.
Yeah, please go ahead. And in chat box, someone mentioned is ASD with
Congenital,
MR. Yeah, that,
congenital actually more than rheumatic. Negative history also suggests for non-rheumatic cause of valvular heart disease.
yeah. In the chat box, actually, nicely they told about ARIA, RV dilatation, and AF in the present usually in the fourth decade, and the palpitation in the ASD typically occurs in the adulthood. That is,
Yeah.
even though the volume overload occurs from the almost from the third year and onwards, but it doesn't produces the symptoms. That is true. Please go ahead for a
Yes.
clinical presentation.
Next slide. Hmm. Patient was conscious oriented to time, place, and person. Weight of the person was 47 kg and height is 170 centimeter. BM of the person is 16.3 kg per meter square. That the patient was underweight. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Respiratory rate was 14 per minute abdominothoracic, and SpO2 was 94% of room air in all the four limbs. Next slide.
Do you think anything is abnormal in this?
And BMI is there. Underweight patient is underweight.
94 percentage, do you consider it as a normal for a 21-year-old male? Okay, go ahead.
Next slide. Pulse rate was 76 minute regular, high volume, collapsing, radial, and corrector of the pulse was pulsus bisferens. But the femoral pulse is delayed and of reduced volume as compared to the radial pulse with the radiofemoral delay which was present. There was no radio-radial delay. All the peripheral pulses were palpable. In the peripheral signs of AR, Waterhammer pulse and Corrigan sign was present. Others were negative.
You
Anyway,
don't have to mention AR here. Just wait. Just to tell about different kind of pulses that you examine. Okay, next.
Ma'am, we have to look for the Muller sign, uvula pulse, and we have to
Yeah,
see
yeah.
the
So
trough.
you look whatever you look, but don't mention the diagnosis of AR here. Just tell the peripheral signs, which
Okay,
supports your diagnosis of that valvular lesion.
okay.
and another better word is peripheral signs of aortic runoff. Don't say
Run
it.
off. Yeah, yeah. Yes, yes. Absolutely, ma'am.
BP in the right upper limb was 138 by 60 millimeter of mercury, and the lower limb right was 96 by 52 millimeter of mercury. In the left upper limb, it was 142 by 66 millimeter of mercury. And the left lower limb was 86 by 48 millimeter of mercury. JBP was normal, 3 centimeter of the sternal angle with the normal waveform, absent hepatojugular reflex.
So what is the information from this? You have a radiofemoral delay and
Yes,
you
ma'am.
have a pulse pressure is how much?
Pulse pressure is, ma'am, uh, 78 mm of Hg in the right
How
upper limb.
much?
Ma'am, systolic minus diastolic 138 minus 60 is 40 30 78, ma'am. Right upper limb.
Okay, with this information, what do you think? What is the likely possibility? Is that gives any clue for us?
Ma'am, radiofemoral delay is present in most likely coarctation of aorta, and there is a wide pulse pressure. It can be AR, aortic regurgitation.
Yes.
Also, the pulse is character is pulse different with the collapsing pulse, and there is a radiofemoral delay as said.
In the upper limb, you have a collapsing pulse, and in the lower limb, you are having a lower blood pressure. So, what is that? Is that gives any severity of the both the lesions? What you are saying, or you can't quantify the severities? What is the
So Parag, ma'am
In
wants
this,
to say that you are having already the signs Waterhammer pulse, Corrigan's pulse,
yes, ma'am.
pulse. So can you tell about the severity of aortic regurgitation based on these signs? Can you just say Waterhammer
Ma'am,
pulse will be
there is
presented?
a hill sign in the BP for the classification of AR. If the lower limb BP is more than 20 to 40 mm of mercury by the upper limb, then it is a mild AR. 40 to 60 is moderate AR, and 60 to 80 millimeter of mercury, then it is a severe AR.
Yeah, is that applicable now here?
No, ma'am.
No. Okay. So now you have a significant lower limb, which you expect. Normally, what happens from the arterial pulse? From the center, it goes to the periphery. What are the
Yes, ma'am.
modifications? Five modifications occurs in an arterial pulse.
Pardon, ma'am. Hmm.
What are the modifications occurs from arterial pulse travels from the center of the aorta to the periphery? You don't know it? Dichrotic notch delays in occurs, and you will have the systolic
Yes.
augmentation. Although the five features you doesn't know, read it.
Yes,
That
ma'am.
is important because those things are going to be then affected in this.
Sure.
And which you expect to be
Absolutely.
the lower limb pulse to be the higher side. Instead of that, that you have in a lesser lower limb pulse. So you can quantify the degree of the coarctation, which is significant in this. So-called
Yes.
coarctation. I don't say as a coarctation. You are already committed as a coarctation. I will say some obstruction in the aorta. It need not to be
Okay.
coarctation. It can be anything else also. Because there are the some other conditions which can be associated with an AR with aortic obstructions.
Yeah.
So always don't commit something in the beginning itself. Once you commit something means you have to stick on to that. So better to use a broader term so that your DD still till the end of the examination becomes keeps to be the broader. Okay. So go ahead, please.
JB was normal 3 centimeter of the sternal angle with the normal waveform, absent hepatojugular reflex. Next slide. Chest was on inspection bilateral symmetrical, and trachea appears to be central. There was no visible precordial pulse, no dilated vein seen, no scar mark seen, no spine deformity. Apical impulse is seen in the seventh intercostal space lateral to the mid-clavicular line. There was suprasternal, epigastric, and carotid pulsation seen on inspection.
So it is what is
Next
the
one.
type of this dilatation then? Your the apical impulse is the seventh intercostal space lateral to the midclavicular line. LV is
Yes,
down and out.
yes, ma'am.
So what is
Yes.
that signifies?
Ma'am, it is a hyperdynamic
Hyperdynamic. So
due to volume overload state.
okay, good. Go ahead.
Good. Next.
Next slide. Apex bit is palpable in the seventh left intercostal space, down and lateral displays, hyperdynamic nature and not sustained. Thrill is present at the right second intercostal space, radiating to the carotid. Also, there was a left Diastolic thrill present in the third intercostal space, but there was no left parasternal heave present.
What is this diffuse and hyperdynamic? I'm not able to understand this apex beat description. When the word is
Ma'am,
diffuse is used,
ma'am, diffuse is when when we can palpate more than 2 or 2.5 intercostal space apical impulse.
so what that usually signifies? What type of the ventricular enlargement will have the diffuse apex beat?
Diffuse will be seen in ma'am heaving type, not the hyperdynamic.
Diffuse will be seen in the heaving type. Heaving
Oh,
is a character.
Hmm.
Diffuse is the spread on the intercostal space. But you are combining those two.
Ma'am, pressure over condition will
Diffuse is
diffuse is no.
ma'am diffuse in the volume overload.
diffuse is in the RV. It is a classical description of an RV.
Yes, yes,
When
okay.
you are not able to localize, and if it is more than one end of
Ah,
intercostal space is an occupies, is an RV. So that doesn't say that this hyperdynamic nature is in a very localized. And it is hyperdynamic is so hyperdynamic that you may feel in the different intercostal space also. But apex beat definition itself is the maximum felt beat. So it has to be the localized. So don't use the word diffuse and hyperdynamic. Both are contradictory. And suppose you want to say both RV and LV dilatation, there should be a gap between the RV dilatation and LV dilatation. You will have a silent gap in between those two to say that the two volume overloads. Okay.
ma'am, actually the patient was very thin build. I was able to palpate in the seventh, but it was also going in the eighth and later on. As you said, it can be hyperdynamic, so it will you can palpate in different spaces.
And all the more reason you have to be very careful to tell about the hyperdynamic. The thin chest individual, even though it is not hyperdynamic, it may look like a hyperdynamic. But in this case, you may be correct because you have another signs of the aortic runoff. So your hyperdynamic nature may be a correct one. Okay, go ahead.
Next slide. Upper of the border of the liver dullness was found to be at the fifth intercostal space, right side and mid clavicle line, right upper border of the heart in the substernal area, and the left heart upper border corresponding to the apex in the fifth intercostal space in the right side mid clavicular line.
Why there is a discrepancy
Uh-huh.
between the apex beat and the percussion? You
You
mean
were writing fifth intercostal space, right side in midclavicular, and your hyperdynamic
It was
pulse, which
not
goes
corresponding to
within,
the apex.
it was not corresponding.
No, ma'am.
you're inviting troubles, Parag?
Uh,
Think for a second time.
don't use percussion.
Actually, when this apex beat and percussion that differs, is there any condition where you can have the apex beat somewhere and the percussion is somewhere? I wanted other students to answer. This is not a frequently asked question. This is a rare question. Only it is happens in the pericardial effusion. Excellent. I appreciate Sri Satya to give that an answer. So actually, when you have this discrepancy, you have to think about the pericardial effusion. And the percussion, you supposed to get the much more than that of the apex beat, what you are feeling. Opposite is not true. Okay, go ahead.
Next slide. First heart sound was heard normally, and second heart sound, there was a normal split of the second heart sound with a soft A2. Coming to the murmurs, next slide.
How do you say it is soft?
Ma'am, comparing to with the comparing with the fifth intercostal area,
So you compare with the space and you say for the loudness of
we will compare the sounds in the second space and the fifth intercostal space, ma'am.
second space and the fifth intercostal space.
And
But
comparing it with the ma'am S1, we can compare with the first heart sound.
S2 is louder than S1 or low intensity than that of then S1.
I'm louder.
Oh, okay. Actually, P2, if you wanted to say,
Too loud.
if you wanted to hear at the base, at the pulmonary area and at the apex, then you can say that the P2 is loud. But for the A2, the comparison is with the P2. Provided the P2 is, there is no abnormality in that. So the A2 is louder than the P2. So the soft and A2, you will see at the aortic area only. You don't see the other areas to say that softness. And second sound is definitely louder than that of the next one. You don't compare with the next one to say the A2 loudness. Okay, go ahead. It is a soft A2.
The first murmur was grade 4 ejection systolic murmur heard in the right second intercostal space, crescendo decrescendo type, best heard with the diaphragm in the leaning forward position, related to carotids. Also, there was a high pitch and diastolic decrescendo murmur heard in along the left sternal body in the third intercostal space, best heard with the diaphragm in the sitting position at the end of the expiration. Also, the third murmur, a harsh systolic continuous murmur, is heard over the left infraclavicular and intrascapular region relating to the back.
Slight modification of your murmur description. What is the endosystolic murmur?
Ma'am, here it is some correction. Ejection systolic was there.
Correction. So at least the presentation you should say it now. Ejection systolic. Excellent. So now you are saying crescendo, decrescendo. What else you wanted to say to know the severity of the or importance of this ejection systolic murmur?
Ma'am, length of the murmur.
Length of the murmur. Okay. What else? When it is peaking, you are saying just saying crescendo, decrescendo is not sufficient. You have to say where that peak is occurring. It is occurring early peak, mid peak, or the late peak. So that will determine what is the severity of your AS. So which is the missing in that. So always all 6 steps for the murmur description. Don't forget about it. If you say all of them, then you will have them. At the end of this, you can say it. Yes, because of this murmur, I can say this is the severity. So coming to this end-diastolic decrescendo murmur, and the end of the this is also high pitched end diastolic heard along the left sternal border. Again, what is the duration? That is also important to know the severity of the AR. Where is the severity is required, you are not given any concentration. So these are the descriptions which is required. If you are wanted to say the severity of AS, you require when is the peaking is occurring. If you wanted to know the severity of the AR, you should know what is the duration of the murmur. Okay? Okay. What is that radiating back murmur?
Ma'am, it was a murmur of coarctation of aorta.
So where it is heard in the infralateral,
Infralateral, ma'am, it was infraclavicular.
so where you will hear the coarctation murmur? On spine, out of the spine?
Out of the spine.
Why? The aorta is not on the spine.
Laterals.
You know, can you say that how the arch descends down? Okay. Your answer is correct. Just I wanted to confuse it is an interscapular. But on spine also you can hear the murmur. But the more predominantly interscapular area, because if the arch comes towards from this taking the origin from the left side, crosses across horizontally, the aortic knuckle forms and this comes down, it is slightly then away from the spine. It is not exactly on the spine from the naboid onwards. As it comes down, when it is coming to the esophagus hiatus, it is coming to the center. Okay, that's the reason why interscapular is much more frequent, but on spine also you can hear. Okay, go ahead.
Next slide. My patient is a 21 years old male presented with a palpitation, shortness of breath, with no history of any chronic illness, most likely valvular heart disease with a severe AR, with moderate AS, with no signs of PAH, currently in NYHA2 in sinus rhythm, with no signs of infective endocarditis and heart failure. Etiology most likely to be bicuspid aortic valve.
Oh, how do you say it's a severe AR?
Ma'am, patient is having collapsing pulse, patient is having Corrigan signs and water hammer pulse, and
Can't
there
it
is
happen
a,
in moderate AR? All these peripheral aortic runoff can't happen in moderate.
it can happen, ma'am. Hmm.
So that doesn't say severity. So go for direct signs of severe AR. Don't go for indirect signs. Indirect signs come second. Previously, heel sign was considered as a very important one, but in this case, it is not applicable. So you can't take it that. In the peripheral signs, only you can talk about that. Okay. Then examination wise, what makes you say that it is a severe AR? You are not
Ma'am,
describing the
wide pulse
murmur.
pressure,
Sorry. That's what
wide pulse pressure.
wide pulse pressure is not a classical of AR. It is aortic runoff. That's all. It happens from the mild to the severe.
Duration of murmur is long, ma'am.
That is that's why I insisted you to tell about that. The
Duration.
duration of the murmur should be the long diastolic murmur. That is one of the direct sign to say the severity of the AR. Then any other murmur will say the severity of the AR.
Ma'am, Austin Flint murmur with MDM
Yeah,
murmur of
fast
Austin.
influent murmur. But some people will say that it is not the severity because it is the direct fall of the aortic jet on the mitral leaflet, which is preventing its a complete excursion. So that is producing a functional MS, and you have the aortic Austin Flint. So it may not reflect, but many of the examiners accept that the Austin Flint murmur usually associated with the severe AR. Anything else? Is
LVS3, ma'am.
LVS3, LVS3 will say severity. It is a volume overload condition. Even the moderate AR also can have it. It doesn't say severity. So, anything with the split of S2? So split S2, is there anything is going to be helpful for us?
So normally, sir, Parag, what happens in severe AS and what happens in severe AR for the split of S2?
Hmm. Just later. Hmm.
Prolonged
There is
ejection
a
occurs.
paradoxical split in the severe AS, ma'am.
Yeah, paradoxical split in severe AS, but even in the AR, it becomes a prolonged ejection. So you will have the wide split pulse may be there, but it's not a direct sign to say that it is a severity of the AR. That is must be there. And you said that it is probably bicuspid aortic. How could you say? What is the classical sign to say it is a bicuspid? Which is lacking in your presentation, which you supposed to mention.
Yes. Yes. What is the sign for bicuspid aortic valve, Parag?
Ma'am,
What is
ejection click.
always? Yes, ejection click is there,
So if the
which
click is there, it localizes to the valve. So its absence doesn't say it. It can be absent in the calcific or the fibrotic, some other conditions. So you can't say that it is a probably bicuspid. There is no point in favor to that to say that it is a bicuspid.
actually, I was just saying that can we say that since the age of presentation is 20-21 years, and at this age we have already ruled out rheumatic heart disease. So in congenital, this particular age is for the bicuspid aortic valve. It cannot be AS or AR. So the reason for this degeneration is probably bicuspid, and also association with coarctation of aorta is again bicuspid aortic valve is having this association with coarctation
Option
of
of,
aorta very
yes,
frequent.
ma'am. Yes, ma'am.
So that is why just probably in the differential.
Yeah. And the severity of the coarctation? And you said moderate AS. What is making you to say it is a moderate AS? Actually, in the presence of the severe AR, you can better to use the, of course, examiners will insist say that moderate or severe. Unless it is a significant AS, it's difficult to make it out because simple severe AR itself can have all the signs. Like it
Yes.
has an ejection systolic murmur, carotid conduction, all those things can happen even with a simple AR. And that too, you when you
Yes.
have a Bispherians pulse. In the severe AR without the ASR also you can have it. So it is very difficult in this situation to say that moderate AS is associated around unless you have the some other signs like the presence
So
of the.
Parag,
Yes,
was
ma'am.
carotid thrill present?
Yes, ma'am. Carotid thrill was present.
If carotid thrill is present, can we say that it is AS?
Occasionally, even carotid thrill is also is told even in the functional AS itself. But as you said, yes,
And what Mother, 2 points for the severity of AS: late peaking of the murmur and carotid thrill.
Yes, ma'am.
he didn't commit it as a late peaking. If it is there, definitely. Then you expect the few of the peripheral signs to disappear. When you have a significant AS, how can you have all the peripheral signs of the AR?
Yes, agreed. But these
Either
two
LV dysfunction
usually
or
don't
significant
exist.
AS should knock down the few of the peripheral signs.
It was clearly from L. We took the pullback from LV to aorta. There was a difference in the pressures, and then post subclavian artery again there was difference in the pressures when we took a pullback, which suggested severe coarctation of aorta.
Project the ECG,
Ma'am,
please.
I had a question. Meanwhile, we are having. Ma'am, meanwhile, he's just showing the ECG. Can I just ask the question that I have?
Please, madam.
Yeah, ma'am. So, discussing the management part of this patient, we had at the level of descending thoracic aorta, at the level of diaphragm, the diameter of DTA was 30, uh, 33 millimeter, and at the severe part of the coarctation, it was 12 to 13. It was severe coarctation of aorta, and so the confusion from and the point of coarctation was almost of the length of 16 millimeters, not more than that. We did a three-dimensional analysis as well. Also, patient had aortic aneurysm in the ascending part of the aorta. So now we asked a surgeon to go ahead with the valve replacement with Pental and also do a quadroplasty at the same time. But our surgeons were reluctant to do Pental in this case, and they were of the opinion that you do the quadroplasty either with a stent or balloon, whatever, and we will just then the pressures will reduce so that aneurysm will reduce and we'll only do an AVR in this case. So the question is that will the aortopathy decrease? Since it is bicuspid aortic valve with coarctation of aorta, there has to be a component of aortopathy leading to that aneurysmal ascending aorta. So will that reduce after doing a coarctoplasty or not? And the second thing is, we should we do just a balloon dilatation of the coarctation, or we should go ahead with a covered stent graft?
The two things, Richa, with your description, what I could understand is that the abdominal aorta level at the diaphragmatic level, 33 for a 21-year-old male is definitely at the bigger size.
Yeah.
And the coarctation, you expect to be the aneurysm of present immediately after the coarctation, or sometimes very rarely before the coarctation. That is because of the pressure effect on that. But it's most frequently after that. It is
Ma'am,
doesn't
it
happen.
is at the level of that sinotubular junction above the STJ also there is aneurysm. That the dilatation of that's why the question of Pental was there. It is almost 58 millimeter above the STJ. It is aneurysmal because of ASAR that has happened. Bicuspid aortic valve, there is aneurysmal dilatation of the aorta.
So AR is responsible for the aortic dilatation and the AS is responsible. So by
Yes.
relieving the coarctation, that is not going to be the released. So aortopathy is not going to be the corrected by this. It is a partially improved
Okay.
for a surgeon to do the limited procedures. not an extensive procedure. Like
Okay.
they have to use the elephant trunk replacement with your
Mhm.
description of the what is the size of the ascending aorta? Aneurysm you said, but you have not mentioned the size.
Ma'am, it is 58 above
That
the
itself
S.
requires a replacement. And you have then aneurysm almost extending to the descending aorta, except in the coax segment. So they have to do the elephant replacement, trunk replacement, which is in a very big procedure. So instead of that, that's why they wanted to release the coarctation so that the pressure effect, instead of the
Hmm.
two pressure effects, one pressure effect goes off. Not for the improvement in the aortopathy.
Okay, okay,
Then
okay,
they can
okay,
limit the surgery to that of
okay,
ascending aorta and to the aortic valve than then extending to the other areas.
okay. So mental they have to do in any which way, and we do coactoplasty.
Yeah, and now I think the covered stand you had to be keep it as an aside because if anything is happens on table,
Yes.
it's better to have it. But when you are planning to do some other procedure, better to have the balloon dilatation, but it should be a graded pressure dilatation. We supposed to avoid the aneurysm formation subsequently because
Yeah.
surgeons by the time the surgeon do the surgery and subsequently develops it becomes a second surgery. It becomes a very difficult.
Yes, yes, yes. So probably with the stent graft only we treat. We should be keeping it on table as stent graft since there is some myopathy also. And there was this thing also that came into my mind. There's a big collateral coming just post coarctation. If we use that covered stent, that collateral will be shut down. I don't think there will be a problem with that. But since subclavian artery is just 16 above the point of coarctation, so that will create a problem with the covered stent.
Yeah.
Ma'am, excuse
That-
me if I'm sorry, ma'am, if I may. Dr. Sowmya, ma'am, pediatric cardiologist. Ma'am,
Yeah.
for a 20-year-old,
Mhm.
doing a cooptation by a surgeon, asking them to do is very difficult because they'll not be able to reach it.
Okay.
For us, a 20-year-old native cooptation, which has not been addressed before,
Yeah.
responds beautifully to a balloon. It
Okay.
actually responds very beautifully. As ma'am said, you have to do a graded dilatation, but
Right.
putting a stent graft and all at this stage, as you said, the left subclavian artery will all be compromised. So just do a balloon, ma'am. It will yield very well.
Okay.
And
Okay.
then,
Okay.
as again you said, the aortopathy and ascending aortic aneurysm is not going to resolve. If your
Okay.
surgeon is not very confident of doing a Bental, just ask them to do an aortic valve replacement with some reduction aortoplasty on the ascending aorta because no major vessels come there.
Right.
If they can
Right. Right.
try to do
Hmm.
that, then you might be able to get away. But if that aortopathy continues, which it will, we have to put him on some beta blockers and try
Yeah.
to control it a bit. But
Okay.
later, he might need a Bental.
Okay. Okay. So I think if two surgeries are difficult, we can just do this graded dilatation of the coact and then send the patient after a few months for the complete mental AVR and mental.
Yes, ma'am,
yeah.
that would be a safer option.
And even that collateral may come down once this gradient comes down. So we need not to worry about the
Yes.
collateral.
Yes. Yeah. Yeah.
Yeah, please go
So
ahead.
that was a great discussion because I was very confused about management. Yeah. Go ahead with the X-ray. I describe the X-ray, Parag.
We have only left over with 4 minutes. Please read
This is a
fast.
chest. This is a chest radiogram of a 20-year old male. Mm, mm. Trachea appears to be
Parag tells
central.
the positive findings.
There is a cardiomegaly present with the apex LV type, and there is also a notching of ribs are also present.
Mhm.
Ascending aorta.
Previous slide. Mm, mm,
At least the
mm.
root of the aorta is looking to be the dilated,
Yeah.
and the one of the line on the left side of the heart is slightly going up, but that is not a SVC. That may be the ascending aorta itself. But there is some notch is seen in between the ascending aortic root and that. So I think if that is a rotation or anything, I think there is a rotation. So that may not be a significant one.
Okay.
Okay, go ahead.
Next slide. This is a 12 lead electrocardiogram showing the sinus rhythm with the heart rate of uh,
No,
68
whenever
per
the
minute.
so many big complexes are there, you should take off standardization.
Mm.
Not just to say that it is LVH is there or not. Anyway, this much of complexes that will go along with that. But other informations we will miss it if you don't take a half standardized lead. Okay. So basically with a LVH, it,
LVH is present, ma'am. Yes, ma'am.
yeah. Strain pattern is not much except
Yes,
the
ma'am.
small QOs, which is expected even in the volume overload. So AR is the predominant. Okay, go ahead. Today echo. Please read the report. I don't think we have the time.
Parag, you have the echo report?
Yes, ma'am. I'm just reading it.
Anyway, severe AR must be there. What about
Ma'am,
Yes.
yes?
severe AR with severe AS and bicuspid
Severe
aortic
AS
wall
means
with
what is the gradient?
Yes,
AS
Parag.
in the gradients. We have peak gradients of 62 and mean gradient of 30 with the velocity of 3.
So in the presence of severe AR, how can you say that is a severe AS at all? Gradients doesn't go along with the severity of the AS.
Right.
Okay. So the severity
There
of
was
the AS is not correct. Next.
Ma'am, there was concentric LVS present and there was a bicuspid aortic wall. LV and LA was dilated and there was dilated ascending aorta. Aortic VTI is 77.2 centimeter. LVOT VTI was 19.4 centimeter. Aortic diameter is 22 centimeter. Aortic annulus is 23 mm. STJ is 42 mm. SOV is 44 mm. Ascending aorta is 51 mm. And AVA by continuity is 0.95 centimeter square.
What is the gradient across cohort? How do you, only last question I want to ask. How the spectrum you expect now if you put a spectrum across the cohort? How it looks?
And peak systolic gradient must be more than 20 mm of Hg. There is a
Classical.
significant coarctation of air.
When the two gradients are there, you expect one envelope over than another envelope. And
Yes.
peak of these envelopes will give you the gradient across to do that. So that is the classical description when that you have the two stenotic lesions. If you don't have that, again you can say that your severity of the AS is not significant. This is simply because of the severe than AR. So you have some AS is there, maybe the mild, and whatever the gradient, 30 gradient of a mean gradient is itself, it doesn't say it is a severe, even for the classical AS. Even for the classical AS, 40 is required.
Yeah.
Mean of the 40 is required. So, and that too in the presence of an AR, it doesn't say about it. Okay, thank you all. And it is a nice description.
Yeah.
Please, Shibba, Richa, and other coordinators.
Yeah, thank you, ma'am. Today, I would also like to appreciate our in the chat box. We've had Sridhar, Sudarshan, Karthik, Abhishek, and a lot of good comments in the chat box. Of course, Parag, you have been very brave enough to face teacher none other than Professor Dr. Jyotsna ma'am, and we all have always learned from her and with great insights. Thank you, dear Richa, for this case. I mean, I think a lot of thoughts put into the management of this complex case. And so, while thanking Dr. Parag and Richa, of course, great thanks to Dr. Jyotsna ma'am. May I call upon Sowmya? Are you here? So
Yeah,
she's,
ma'am.
the heartline of our e-classes. So all off to you.
Thanks for a huge, nice introduction. As Dr. Shibba said, it's an excellent case. And, I think all the postgraduates should share this link to other postgraduates and encourage them to join. Learning from one mentor is different, and learning from other people from other institutes is entirely different. And also, we encourage all the postgraduates who were active in the chat box or inactive to please participate in that WinCards postgraduate quiz.
Soumya, before you leave, there are just two comments by anonymous attendee. Could you address them because they're all related to coact? I
Yeah,
think
ma'am.
can increased
Surely.
LVDP in coact change the duration of AR murmur? and no diastolic gradient across the coarctation.
Okay, I'll try to answer the no diastolic gradient across the coarctation. When you have a severe coarct with severe AR, the diastolic gradient might not be there. There'll still be a diastolic spill. Even though echo gradients in the coarct are there, the most important thing is the difference in the upper limb and lower limb blood pressure, which we take clinical.
Yeah.
So even though if you have a gradient of 20, which is seen in the echo, if your blood pressure difference says that it is 40 between the upper limb and lower limb, you still say that it is a severe coarct. And stenting of coarct if finances are not is not an issue. Okay. Stenting of coarctation we usually reserve for patients who have a long segment coarctation, which means that you have a significant length of that coarct. In coarcts associated with bicuspid aortic valve and native coarctations, which were not repaired before, it will be one discrete stenosis. It will just be at one point, which is like a ring. And they actually respond beautifully with a balloon initially. And then if they have not yielded, if there is still a gradient, then you can go for a stent. The other thing with stenting in coarctation is that you need to have CP stents, which are very, very costly, or Andra stents. Not just costly, they
Yeah.
require a huge access from the femoral. They require at
That's
least
the
a
problem. Yeah.
12 French or 13 French access,
Yes,
and
ma'am.
closing the femoral access again is a difficult issue. So we reserve stenting for patients in whom the balloon has not yielded the result. Even though classically the teaching says that in adult coarctation you have to stent, no. This has been our experience. Please do a balloon first, it will yield. If it has not yield, you can go back again after 6 months and then think about stenting.
Okay.
Uh,
Okay.
can increase LVEDP in coarct change the duration of AR murmur? Yes. But if the AR is a significant lesion and there is a severe AR, still your diastolic murmur will be prolonged. The severity of coarctation increasing the LVEDP, the AR itself will increase the LVEDP first, right? So that change in the murmur might not be very significant. I hope I've answered it. So,
Perfectly.
before any delay, please attend the postgraduate quiz, as I was saying in the WINCARS upcoming conference, which is coming. And we should do more and more classes like this. And you can volunteer yourself. You can just find our numbers and, tell us if you have any good case which you have to present. We can coordinate. We are always there to help. So, good job, everybody. Good night. Thank you.